So you can see from the poll here, something that actually really surprises me a little bit, which is the prominence of economic stability in those folks who responded to the poll. Education and access to healthcare are pretty low. Social and community contexts and neighborhood contexts are closer to one another, but even the top one, neighborhood and built environment, are half as prominent as economic stability. One of the next slides I'm going to be sharing with you after we hear back from the groups has to do with, well, it's a map. Most social determinants of health data are displayed for us in maps frequently. Like it's actually uncommon for social determinants of health, either research project or intervention, to not have some kind of geospatial way of displaying data or a way of understanding the design of the intervention or the implementation of it. And so when I was thinking about the slides of maps, excuse me, that I might share with you, there was one on the Gini coefficient. I don't know if everybody in this group is familiar with the Gini coefficient, but it's a measure of inequality. And so there's this wonderful map online. It's a map that changes with the decade. And it shows the Gini coefficient for every state in the United States since the 1970s. And what you can see on there is that inequality has gone down, 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 down with every passing decade. And so I was thinking, watching it, and I'm not sure I'm going to share this with these guys because, or these trainees, because this is, you know, kind of, we know the story here, until I got to the last couple of decades, and the Gini coefficient for most states was rising, so inequality was rising. And so actually looking at these results where economic stability figures so prominently, maybe I shouldn't be surprised. But I'd love to hear from the groups who just spoke in the two breakout rooms. Let's start with breakout room 1 and hear from you about how did your discussion go about these primary drivers of social determinants in your community.
And just make sure to remember to unmute yourself so we can hear you.
Yeah, who from group 1 wants to talk about what your group discussed?
This is Julie. I'm in Helena. Most of us talked about economic stability in our areas, whether that was Montana, or I think we have a lot of Colorado folks too.
Yeah.
And some of that's related to COVID, some of that's not. We also talked about how economic instability affects everything else as well, transportation, being able to participate in cultural activities, especially on a reservation. So that's mostly where we landed.
How many folks in your discussion room are working with tribal or American Indian populations? Was that a pretty common experience?
We didn't take a poll of that, but one person specifically was saying she's on a reservation, works on a reservation.
Yeah.
And I certainly, in the cancer screening program, even though I'm in Helena and all we have is an urban Indian clinic, we have a special, not a special, but we want to reach as many American Indian women as possible for cancer screening.
Smart. Other folks from group 1 want to talk about the economic factors in their communities and how they see those as impacting health outcomes. Somebody mentioned, I think it was Julie mentioned transportation. What else though?
This is Stephanie. I was in group 1 and I also had selected economic stability, but I was thinking it more from like a housing perspective, because I'm here in Bozeman and just it's really hard to find affordable housing in this area.
Yeah. And how do you think that affects health?
I mean, if you don't have a place to live, then I think it just kind of contributes to that, how economic stability, kind of can really quickly escalate And if you don't have, that stability, how can you pay for, getting transportation or getting quality services or accessing health services? And I think a lot of people like to live in this area because it's, it's a pretty healthy part of the state. There's lots of outdoor recreation. But if you can't afford to live here, how can you take advantage of those other, qualities?
Right. I'm glad that you brought up the sheer homelessness component. There are other attributes of when housing is expensive that end up being explored or targeted in different housing-oriented initiatives or interventions that use the social determinants approach. So let's remember that, and I'll circle back to that later, Stephanie. Thank you. What about from group 2? I popped into group 2 toward the end and listened to your discussion as well. Does anybody from group 2 want to share some of the primary things that came out of your conversation?
This is Jolene. I'll jump in to say a few words. A primary for the, I actually chose health and healthcare because that's my focus here, but, and it's been identified as a missing component here in Lewis and Clark County. But, the economy was, economic equality was identified as the biggest issue because it's universal. But if you're, and it does make sense because if you helping Maslow's hierarchy of need, you have to have food, shelter, and safety before you can move forward in advancing and helping yourself in other ways. Yeah, so that's I think, and we've talked a lot about neighborhoods and the equality that you have within it, and for economic opportunities for buying food for places that are food deserts, transportation. It's all so connected. It makes sense for having a universal or taking a big picture view of the whole component of how we're connected in those in our communities and in the economy. As
Jolene,
targeted. Yeah.
Did I hear somebody in your group mention a project or an intervention that they're already engaged in that is targeting some of these challenges?
I know both Carissa and I are involved in that right now. So our focus again is, been identified through the community health improvement planning that's done every 3 years here.
Yeah.
9. And it identifies the areas that are standing out as the biggest issues through communication through nonprofits in the community.
Yes.
The large hospital in the area and the public health department, and also the police department.
Okay. And somebody else in the group also used the CHIP approach to
that was
developing this.
Yeah, so I was asking Carissa a lot of questions to get some of her shared information to see how I could pull that into what we're doing here too.
Yeah, that's great. And who was the other person that you mentioned? Carissa? Oh, okay. Hey, Carissa. I just clicked onto your view. And so Carissa, do you also use that kind of stakeholder approach that Jolene was just describing, where the hospital, the local hospital is involved as well as the police department or what have you? Okay. Are there any other stakeholders you wanted to mention?
The hospital and then the clinic too, which are different entities, but.
Sure. Yeah. Yep. And that was part of their community health outreach.
Yeah. And that was driven by the need to survive on grants.
Yeah, I hear that. All right, thanks for sharing those things. Does anybody else want to share anything for right now that came out of those discussions, knowing that we have a couple other opportunities to discuss other topics relating to this? All right, so we'll just move on from that then. So that's really, really interesting to me. I work extensively with folks in different jurisdictions across Montana who inhabit different roles, some of the same as folks that have joined us today, but also more on the clinical side and more on the academic side. So this is really interesting and good feedback for me to consider and fold into future work having to do with the maternal health initiative that I talked about, but also a couple of other grant-funded activities that I'm working on that touch on many of these issues. So what we have on the screen here is, where are we? I wanted to talk you through some particulars having to do with social determinants of health and practice, and some of the common features that are shared among interventions that embrace this approach. So the first is access or making access to parks and safe sidewalks for walking better, frankly. Simply associated with reducing conflict between pedestrians and traffic, but also with aimed at improving physical activity outcomes and the likelihood that people are going to walk places in the first place. So that's a very common feature of a social determinants of health approach to the built environment and neighborhood considerations. And I'll talk about some specific interventions that do a little bit more with this in a little while here. Education, improvements to education and increasing the likelihood that people will stay in school, that school retention rates are high, that graduation rates are high, and that attendance rates are high. I suppose it goes without saying that education is associated with all kinds of positive health outcomes, improvements there. And so I won't belabor that point. We also see in many social determinants of health interventions in a concern with improving circumstances in the workplace, frankly. We all, those of us who work, are spending a very significant proportion of our time in the work setting. And so there are lots of social determinants interventions that are aimed at improving things like discrimination or stigma or unfair treatment in the workplace. These things have been shown in the study after study. There's a good evidence base to show how reductions in discrimination can improve a variety of health outcomes, including blood pressure, heart rate and stress, and also in terms of mental health and behavioral health outcomes, we see many improvements there as well, including with respect to self-esteem and self-efficacy. I want you to remember that term of self-efficacy because I'm going to be returning to that in different contexts with different kinds of interventions that you might not think self-efficacy plays a role, but in fact has played a profound role. Also, we see lots of programming and interventions aimed at family and community rejection, things like bullying people, folks who identify as lesbian, gay, bisexual, transgender, what have you. This is all very much on our minds today, I think, not just because of the Black Lives Matter movement, but other movements that have highlighted the significance of bullying for people who identify with what can be understood to be minority populations, and the profound impact that that has on their health outcomes down the line. And then last point that I wanted to make here about another kind of general category of social determinants interventions or implementation projects have to do with diet and improvements in diet. I think somebody mentioned food deserts before, and that's a neighborhood where people lack access to affordable and healthy food, and those are increasingly common. I think a lot of people associate food deserts with urban areas, but in fact, food deserts are just as common in rural places. So there are some data in that last dot point about the number of people who live in places where they cannot routinely access healthy and affordable, good and nutritious foods. And so that's also, as a result, a focus of a lot of programming in the social determinants kinds of interventions that we see. Like I was saying before, importance of place is very high in most social determinants analyses, and so the appearance of maps is very, very common. I'm wondering if we narrow in on our state of Montana or Colorado, if anything jumps out. I think those are the two main states represented in our trainees today. What jumps out at people from the counties here? So this is life expectancy at birth. Redder is worse and blue to purple is better. What do you see, folks who are familiar with the states and the counties they're in? What do you see that jumps out at you? Stephanie, you want to have a go?
Yeah, well, I just see that I think Gallatin County there is probably one of the more blue-purple counties.
Mm-hmm. Which you observed in just a few minutes ago. Mm-hmm. Anything else?
Yeah, and then I think, so over, gosh, I'm not from Montana originally, so my ignorance about the counties is gonna come to light here, but I think over towards Billings, I think, is that the Crow Reservation?
That would be the Crow in Northern Cheyenne, yes, in yellow. That county that you see in yellow, yes, or orange. Mm-hmm.
And then also up in the northeast corner, that really red area.
Anybody know what that is?
The Fort Peck Reservation.
Roosevelt.
Thank you. Yes, that would be Fort
County.
Yes, ma'am.
And then we have the Blackfeet Reservation up by Glacier as well.
Exactly. So that jumps out at you, and that's one of the great things about having mapping exercises like this, is that it makes these differences plain. Let's look at some other maps though. So this one here I like because it zooms in a lot more from the county level. These are looking at two cities in Illinois and Mississippi, and shows us life expectancy at birth for different zip codes within these two cities. And what do you see here? Any geospatial patterns? People are probably familiar with the south side of Chicago, or have heard of the south side of Chicago being referred to as a predominantly African-American set of neighborhoods. So you can see there, the south side of Chicago has a relatively lower life expectancy at birth. What else jumps out at folks from this? Any other neighborhood effects?
It looks like in Mississippi, the further away from the road you are, potentially the lower.
That's absolutely right. Emily, do you know about the history of the building of highways and throughways in this country and the relationship between that and race?
A little, but not a ton, no.
There's a long history there, and those two factors are very much related and have been historically since the inception of the national highway system. So yes. Anybody else want to chime in on this particular set of maps?
I was just going to say too, you have a question in the chat box whenever you have time.
Oh. So the question is from Julie. Examples of how public health has been involved in efforts in improving economic stability. Yes, I have a couple of examples that we'll get to a little bit later on that, Julie. So thanks for that question. Some very specific interventions that I hope will give you some ideas of initiatives that you could pursue in your community. So yes, thank you. I won't jump ahead in the interest of kind of keeping to my syllabus, but I will circle back to that. We see here the homicide rate by neighborhood in Chicago and Brooklyn for 2016 data. Again, reflecting the significance of place and community and the impact of those things on how long and how well you live. I think for folks living in rural places or states like Montana or Colorado, it can be easy to imagine that factors like this don't exist, but indeed they play a massive role in affecting health and health outcomes, specifically mortality outcomes here in this graphic with homicide rates in other parts of the country. So just to kind of remind everybody of that reality. Here we have a graphically demonstrated through, again, maps, relationship between food insecurity and food deserts. So we've talked a little bit already. Some people have mentioned food deserts, and I brought them up a couple of slides ago. But it just shows the significance of understanding the geospatial arrangement of populations that are more or less affected by food insecurity. And so you can see in Mississippi, the clustering of very food insecure neighborhood or counties in the northwest part of the state, and how well, in comparison, Illinois is doing. So the Mississippi rates are nearly double on average what we see in the map to the left, but some counties, many counties actually, are doing considerably worse. I wish I could find these data to show you for the states of Montana or Colorado, but I couldn't find anything recent enough that would be useful to share. Here we can see three identical maps for Chicago. One is food deserts, the other is life expectancy, and the other is unemployment. Again, showing the clustering on the south side of the city of the intensity and negative health outcomes or negative food desert attributes in the southern parts of the city. So you can see, if you overlay maps on top of one another, how a lot of these factors will typically line up. And so here we see, zooming in on what's happening with children. This is non-metro related child poverty rates by county. And again, you can just, if you want to take the example of Montana, you can see those same counties standing out, plus a couple of others that we discussed before. So primarily those counties that are housing large numbers of American Indian people or tribal populations because of reservations or what have you, not exclusively, but primarily. Well, good old COVID-19 has shown its face in Montana, and indeed the map helps us understand the distribution. This is early in the whole affair, so this is going back to data from March, early first half of March, but I'm guessing that this information is very familiar to folks in this group who are working in public health in Montana, but again, shows the utility of understanding that geospatial approach. So when we think about the social determinants of health for maternal child health programs, which is, as I said before, one of my areas of specialty, we can see a couple of things going on. So these four bullets have to do with the primary drivers of maternal morbidity and mortality in the United States. And so I started out with obesity. So fully 1 in 5 women are obese at the beginning of their pregnancy here in the United States. And then if we look at obesity rates by county in the United States, this is 2010 data, that's actually the most recent I could find. And you can see for the state of Montana, there are, again, these county effects that relate to either the distribution of population by race and ethnicity in the case of tribal versus non-tribal populations, but also I think extreme rurality and folks living in highline communities. So those northern counties up along the Canadian border also are experiencing higher obesity rates. We also see in this next slide, approximately 12% of pregnant women in the United States are smoking during their pregnancies, and another 12% consume alcohol. 12% of pregnant women surveyed had consumed alcohol in the last 30 days. So if we look over here on the map again for states that smoke the worst, we can see, unfortunately not county level data, but we can see where both Montana and Colorado figure. Montana figures a little bit worse than Colorado in most health metrics, but certainly in the smoking. The next two bullet points pertain to the use of folic acid supplementation among pregnant women. For the United States, there aren't good data that I've found for either state or county level pertaining to taking folic acid or what taking folic acid is related to in terms of the social determinants. We know for obesity, smoking, and alcohol consumption that there is a very clear linkage between those behaviors and features I've discussed already with social determinants, including all attributes of socioeconomic status, but also attributes of environments that people live in and features of social cohesion, which I'm going to be explaining in a few minutes. Folic acid, though, we just don't have those data for this country. I think primarily because United States is among a large number of nations that fortify grains with folic acid, and so it's just sort of assumed that most women are getting supplemented with folic acid through the consumption of grains. But as we know, additional folic acid supplementation during pregnancy is recommended, but we just don't have those data displayed in a graphic such as this one with smokers in quite the same way, unfortunately. I keep smiling every time I say we don't have data, and that's because I'm thinking of a point that I'm going to be making a little bit later today pertaining to data that you need to be collecting in your sites and with your populations, because surveillance is key. Surveillance is king. The more data that you can collect on some of these disease processes or these health behaviors and their outcomes, the more effectively that you can argue that you can argue for funding to come your way or for programmatic focus to be on those processes. The last point on the left here has to do with the approximately 1 in 10 women who are depressed during any trimester of pregnancy or any month within the first year after delivery. So postpartum depression or prenatal depression is a major determinant of maternal morbidity and also associated with maternal mortality. And these are, again, data that are not well displayed graphically, or at least in map form for me to display to you, and begs for more data, and that's where you come in. I also wanted to drill down a little bit more into drug use. I mentioned before that I'm working on this maternal health task force and trying to improve maternal morbidity and mortality in the state of Montana, and substance use disorder. This won't be surprising to anybody on this call. It ranks very highly in terms of primary drivers of both morbidity and mortality. What do you guys see here, again, shown in this particular graphical representation of drug overdose, and we can assume that that's a proxy for drug use for this exercise. So these data are from 2009 to 2018. What do you guys see here? Any pattern jumping out?
It seems to be a little bit more prevalent in the more rural areas of Montana.
You could see a rurality piece. Mm-hmm.
I believe there's also a correlation with reservations.
Mm-hmm. That's what I'm seeing as well. Yep. So again, I'm mirroring some of the data that were displayed in the earlier maps.
I would actually argue that in the rural areas, there's insufficient data. Never mind.
I think I know where you're going with that, but yeah, that is insufficient data. Okay, quick question having to do with folic acid. I think I'll circle back to that one, Jolene, because that was just from you to me. So I'll come back to that folic acid piece. Okay, so where are we up to here? I said in my agenda that in this section, in addition to looking at some of the primary drivers and how they are influenced by space, I would be looking at maternal health, but I also want to talk about the health of children. in these kinds of settings, particularly rural ones. So children's health is also profoundly affected by these kinds of social determinants, chiefly income. You all have already mentioned that as something that's a driver, or income inequality is a driver of health and health outcomes in your community. But in the next discussion room, I'd like you to think specifically about children, and then secondly about pregnant women. So in addition to income, we also see educational attainment of parents playing a massive role in the health outcomes of children, as well as features of the community playing a massive role in the health outcomes of children. And when I'm talking about health outcomes, I'm talking about both mental health and mental behavioral health, as well as physical health. So when we're adding rurality into that picture, the data show that the picture changes a little bit. So studies of differences between rural and urban children have shown a couple of interesting features. One is that rural children actually experience higher rates of poverty than their urban counterparts. They're more likely to be insured by Medicaid rather than private insurers. They're more likely to be overweight or obese. They're less likely to receive preventive medical or oral health care. And they're more likely to die than their urban counterparts, and that's mainly due to unintentional injury. And those unintentional injuries are mainly associated with farm work. And I know that a lot of people around this country imagine that there isn't a lot of that kind of work or those kinds of accidents happening anymore. But I think those of us who live or are from rural communities understand that that's still a big part of the lifeways of many people in rural places. And that children do experience a disproportionately high burden from accidents relating to that kind of work. So those data are fairly robust and show those differences between urban and rural settings. So these two graphics help us see for women of childbearing age and for infants, so birth to age 1, what are the major health issues? And so you can see here that these data are a bit older. These are 10 years old, again, calling for the need for more recent surveillance and for the role that you all can play in this here in the state of Montana. So we see on the figure on the left, the significance of obesity or being overweight or experience of weight gain. To the left in the gray solid, we have lack of family planning or problems or access to reproductive health care. The dots on the top left, lack of education, and to the right, access to medical or primary health care for those prenatal visits, for attended labor and delivery, and for care during the postpartum period. And on the right, we see for infants, the significance of prematurity and access to health care. But there are other things that I would say are more associated with what we've been talking about today with respect to the social determinants of health, where children in that very vulnerable age of 0 to 1 are experiencing major health issues from poor nutrition, from their parents' lack of education / parenting skills, lacking immunizations and vaccinations, and the shortness of the duration of the breastfeeding period, which feeds into the poor nutrition piece. So over early introduction of solids, and the introduction of solids that are associated with diarrheal conditions or poor growth or failure to thrive or what have you. So in terms of ways forward, there is some sort of emerging consensus about the ways that we can use the social determinants of health approach to target and tackle some of these challenges using that overarching rubric or that holistic, or as I described it before, that multi-pronged way of thinking about these health issues and how to target them. So for beginning, to begin, we have things like programming that targets maternal child health, aiming at programs that bolster provider availability. That's always a challenge in rural areas, the retention and recruitment and retention of providers, and getting them to stay and form those long-term relationships with their patient base that lead to the best health outcomes. Not just clinicians, but also public health practitioners. We all know that the turnover in public health practitioners is also very high, particularly in rural places. And then increasing financial access to care, maybe through the Affordable Care Act or other approaches that are even more innovative, including grant-supported activities with appropriate operational targets. And that's really, I think, where we as public health practitioners can focus the bulk of our attention, is that going after those grant-supported activities, especially those grant-supported activities that span more than 3 years, preferably 5 years, with operational targets that help us influence long-term behavior change that will improve people's health outcomes over the course of the lifetime. I do say that the above go without saying, practically. So what else is there? As I mentioned before, we really, really need improved surveillance. A lot of the data that I've cited to you so far today have been 10 years or older. We just don't have adequate surveillance on some of these processes. And without data from our own communities, problems can't be defined and policy solutions can't be suggested or documented. I would strongly urge you as people who are considering taking the social determinants approach to do surveillance exercises that include features of the social environment that are relevant, that are known to you because you live in those communities and you work with those people all the time. So things like, you know, do people have the ability to exercise? Are there sidewalks? Are there places where people can exercise safely at, you know, in different seasons of the year or what have you? Are people experiencing the ability to purchase nutritious foods or not, as two examples of things that you will know about your community that need to be brought to the fore potentially, but maybe there are other things about your community that will affect people's ability to achieve their long-term health goals that do fit under the social determinants of health rubric that are different from exercise or food deserts and that sort of thing. Another sort of emerging trend that we're seeing is an increased emphasis for rural places on mobile vans and buses. Our role as public health practitioners is to determine for what. So one of the things that's emerging from the Maternal Health Task Force is that we are working with critical access hospitals in lots of eastern Montana counties where we are, you know, really targeting clinicians that might not have an obstetrics unit, but might have to deal on occasion or sometimes more than on occasion with a drive-by delivery of somebody who can't make it any further than the critical access hospital. They can't get into a larger unit or hospital setting. So some of those communities, though, they don't want obstetric training. So that's been kind of like, gosh, you don't want free obstetric training, talk to us about why. And they've explained that the demographics in their county are not, you know, obstetric training is not a need. They need assistance with caring for stroke patients because they have an older population. So knowing what the components of the health challenges that face your particular population are absolutely key, and can be a little bit, I think, difficult to discern if you're new to your position, but should be something that as you grow into the job or into the new role that you inhabit in it, should be front of mind for each one of you. And then last but not least is an increasing emphasis on telehealth or telemedicine projects. I'm sure that's something that folks are familiar with especially during the time of COVID. And the absolute need for a lot of physicians or clinicians of various kinds to move their practice onto the telehealth or telemedicine platform. But even absent COVID-19, there are more and more initiatives that we see that are telehealth or telemedicine focused that include a social determinants of health approach and integrate them into the interventions suggested. Okay. So now we're up to polls 2 and 3. So Emily is going to help us by posing 2 different polls. The first one has to do with what you would expect your community's heaviest social determinants of health to be for your children in your community. And then separately, what would those be for pregnant women? Let me give you a couple of examples. If you're working in a catchment area where there are lots of Hutterite people, for instance, Hutterite people are known for having very high fertility, large family sizes, and also for having a social system and a set of religious beliefs that would mean that that decision making about the control of fertility lies more heavily in the hands of male members of the community or with husbands than with female members of the community or wives. And so, as a for instance, understanding that social factor would be very important for understanding how pregnant women think of, seek, and receive healthcare during pregnancies, specifically relating to the way that they may be interested in or accessing contraception, as an example. So in the Hutterite thinking and religious framework, using modern contraception is not permitted. And so that kind of thing can be, in Montana, we have lots of Hutterite colonies or other Anabaptist groups, like there are some Mennonite families in some of our communities here in Western Montana that can really affect things having to do with the way that women seek healthcare during pregnancy. So that's just an example that might inform your thinking as you fill in this poll and go into this next discussion.
Yeah, so we've got the first question up, got about 8 responses so far, and then we'll have, once we get most of these folks in, I'll throw up the second poll. They weren't in the same one, so.
Yeah, they have to be separate because there'll be slightly different things that are affecting pregnant ladies versus children. I'd love to hear from our Coloradans about communities or groups that are different to sort of mainstream Coloradans that may have social factors that are affecting these kinds of health behaviors, like I was mentioning before. I'm not sure if you have many Anabaptist communities, or perhaps there are some other religious groups. Here in Montana, we have some FLDS communities in some towns that have different ideas than sort of mainstream Montanans might about fertility control, etc. So there are some really fascinating variations from one community to the next, even just here in little old Western Montana, but I'm thinking like in your context elsewhere, those variations might be even more significant. So let's see what you guys come up with. Okay, so that's for children.
So that's, we got about 20 there.
Super. So can you pop over to pregnant women?
Pregnant women, there it is.
So let's pop folks over into their Zoom rooms, their breakout rooms.
Okay.
So let's do the same groupings as before.
Perfect. So you'll see an assignment, and then I will pop into the rooms and add these screenshots just so you can remember them, what you guys voted for. So your little rooms are open, should be the same ones as last time. And I will get in with these results right away so you can look at them.
All right, I think everybody's back, or most people are back here. And so let's do our round robin sort of roundup of what came up in your individual conversations in those 2 breakout rooms. Let's start with breakout room 1. So what did you all discuss there? I popped in and listened quietly for a while, but Stephanie, were you in 1?
I was.
Should we have Brian talk?
Only once. I'm happy to share like the couple of points that I mentioned.
Yeah.
And then if Brian wants to speak up.
I'm teasing because Brian was saying he's happy for you to lead, which is wonderful.
Yeah, so I kind of had a hard time thinking about like what the best selection would be for children and then for pregnant women. Because I was thinking through the mindset of like childcare providers.
Okay.
And so, and I can see it could be applicable for both, one, getting a child into a quality childcare provider so that they're getting, a good education and they have access to healthy foods at that provider. And then also as a pregnant woman or someone who has recently had a child, thinking about making that transition if they want to go back to work, and then trying to find a quality childcare provider. I know in our area is especially difficult just because they don't think there's very many licensed providers. And then with COVID, just kind of exaggerating that, I think several providers have shut their doors forever, just because of COVID. And then otherwise, you know, as things reopen or people's jobs may or may not, they may or may not be able to go back to their jobs, and getting their children into childcare is just, can be really challenging. So that was kind of what I was thinking about as I was considering these questions.
Mm-hmm. So you're thinking of the preschool age children and what they'll do when their folks are at work primarily, by the sounds of it.
Yep.
Yeah. But with obvious knock-on effects for women of childbearing age, if they have children in that age group, then they're likely to have more than one. And so for them, like finding that care while pregnant, et cetera. So there are all these ripple effects, aren't there?
Yeah. And I only know this from, you know, my coworkers and my peers, but I think especially here in Bozeman, like if you are pregnant or if you have children, you almost have to get on the wait list for childcare, like months, sometimes even years before, you know, you have your child. So
yeah. And you're in Bozeman?
Mm-hmm.
Yeah, that's how it is here in Missoula as well. Other folks wanting to weigh in on some of the social determinants that might affect child or pregnant women's health in their communities or practice areas? From group one. Brian was saying he was having a hard time narrowing it down to one thing, which I do understand. And from the poll, what we see is that, I don't know if Emily can display that real quick for the conversation, but for the poll, what we see is that the social and community factors for the social and community context featuring fairly highly, but also the neighborhood and built environment. Folks want to talk about that with respect to healthy or social determinants that would affect the healthcare or health outcomes of children? Oh, actually, I was citing the data for pregnant women. Sorry. I'm looking at my notes and then at the screen, which are different things. So for children, we see, social and community context and then economic stability up there. You guys must have been like, I must be looking at a different poll.
I just shared the pregnant one again. So I can put the kid one back up.
That's funny.
So this is the pregnant woman's one.
Let's stick here. I do believe that it was Jolene in group 2. I think so. Group 2 was having a longer conversation about folic acid, which I found quite interesting to listen to. Do you guys want to share with the broader group what you were on, what that topic was?
This is Jolene. I did a lot of talking on the last one, so I will give the floor to and ask Tracy Roberts to step in. She really had a lot of good things to say.
Thanks, Tracy. I think you were talking about folic acid, whether or not you as a patient were apprised of the need for folic acid, or what kind of information was this just sort of assumed that you had by your provider, and then you were thinking about how that affected others who are maybe even less empowered than you.
Is Tracy there?
This is Amanda. I'm her coworker. She works like next to me. I think she's had to take a, she had to step away. Okay. So she may not be there. You might want to try again, but.
Okay. Do you remember what she said, Amanda? Were you in the same group with her?
I was, but I went on the bathroom break too.
Oh, you were.
I don't fully remember. Sorry.
That's
okay. I mean, I think Jolene was asking her some pretty good questions.
I was asking her some questions, but I have definitely not so experienced in working in the field in regards to maternity and childbirth and stuff. But I can, voice from my own experience too is, I think young mothers especially need education. And to me, that was one of the biggest things. Because if somebody has income, that doesn't mean they're going to have a healthy baby unless they're educated on what, you know, the expectations are. And I know, actually, I mean, I didn't learn till recently the folic acid piece, but I remember back in the days when I was pregnant, was, you know, they gave really a heavy duty multivitamin at that time, which included the folic acid, which I don't think they do that anymore. You know, I never knew really the implications of it, but how important it is in the development of the fetus in the first trimester, which is key to the foundation of the development of the healthiness of the child. I mean, so for me, education was it, and then Tracy was talking more about social construct and the influences. But anybody else want to jump in to talk about other areas that were they thought were important from the group discussion?
If not, we can circle back to the question that you posed, Jolene, which had to do with do gynecologists or obstetricians track folic acid upon initial confirmation of pregnancy in Montana? Not to my knowledge, no. You're talking about running some blood work to determine what the folic acid level was, yeah.
Yeah, I mean, the conversation, but to confirm it in the blood work, which is pretty easy to do, right?
I just actually went down this route, not in the case of a pregnant person, but I don't think it's standard actually for most practitioners. I think you raise a very interesting point though, that as more and more people switch over to gluten-free diets or either not eating grains or relying upon grains that haven't been fortified, like other kinds of alternative grains that people are using for baking products like spelt or what have you for bread, non-wheat grains, I do not believe those are fortified in the United States. And so you raised a really, really interesting point there, that even that sort of baseline unsupplemented with prenatal vitamins level of folic acid for such individuals might be lower. So that's a really good, yeah, it's a really important thing to think about.
And my perspective is I've just been diagnosed as gluten intolerant.
Is that right? Okay.
Yeah, just about, probably about 8 to 10 years ago. But I wasn't aware of it at the time when I was pregnant. But I think that it's something important, and I do know a lot of people who have to practice gluten-free diet, and they're young and haven't had children yet. And so I think those are things that people can't assume pregnancy is naturally comes with all with no complications. It's a miracle that it happens and the child is healthy most often, but to ensure that, and obviously the health of the mother too, but so those are just some of my insights. And you know, as my experience in life with being low income, you know, I was responsible to raise my son after divorcing at a young age. And you know, the value of programs like WIC are so important for nutrition value and education for young mothers too. I think that's an important thing too. Why I say the education is really important, and then the other benefits happen with that. But I'm sure it's an issue here too. I don't know all the statistics here about that, but I would love for somebody else to talk a little bit more about their knowledge.
In addition, I was in break room 2. I know that we don't really test for genetic mutations such as the MTHFR gene. That gene, if you're heterozygous, can inhibit your folic acid, your ability to process it by up to 20%. And I believe if you're homozygous, it's up to 40%. And I think that would be something that maybe we could test for at the beginning of pregnancies so that we can help balance out or help give a different supplement or whatever it would be so that pregnant mothers who can't process folic acid could process it properly.
Yeah, that's a really interesting point, Erin. I actually just went down this rabbit hole with a family member testing for MTHFR, and also just getting the folic acid versus the folate blood panel, or that blood work done, was not as easy as you might imagine. That's why I don't think it's standard of care for pregnant women in the state of Montana. By chance, we had a visiting speaker here in our program in the School of Public Health whose expertise was in folic acid supplementation. And so I asked her that very question, Erin. So you and I are just definitely thinking on the same wavelength with respect to understanding the role of MTHFR in folic acid or folate uptake among pregnant women, and the possibility that over-supplementation with the wrong form of folic acid could have results that are not the intended ones. But she couldn't answer those questions. So it seems like it's really, fairly poorly understood still, at least from what I understood from her answer to my question. But thanks for raising that. So interesting.
Yeah, thanks. So Kimber, so most of this comes from your point of surveillance and the data. I mean, if they can start tracking this and to see if it is an issue.
Yeah, absolutely.
Be addressed.
Yeah. But I had to go, it was not easy to get the blood work done. I had to go to a special lab. So I think that there are these inhibitors that are going to kind of militate against, especially people with lower self-efficacy or less funding for healthcare, to seek these kinds of treatments or even diagnostics. I see a question in the chat from Amy. Thank you, Amy, asking the group, what are you doing to train around the stigma of programs like WIC or SNAP, which I think is such a great question. A lot of the interventions that are conventional in rural and urban in the state of Montana, whatever that means, for addressing some of the social determinants of health are federally funded programs like WIC and SNAP, and they are so stigmatized in many communities. Have people had success in dealing with the stigma piece?
Where I live, I think that word of mouth is more powerful than like advertising. And so people share their experiences with their network, and that's kind of how our programs continue to sustain.
Mm-hmm.
I don't really think WIC or SNAP has a stigma where I am, not in the same way that like mental health services do.
Yes.
And I'm not really sure if that's because there's such a lack of resources, and WIC and SNAP is something we actually do have, so people want to engage.
And where are you again, Carissa? What county?
Mineral County.
Yeah.
But it also could be that there's been great relationships developed out of the health department with the home visiting program, and so it's not intimidating. Mm-hmm. So I guess I'm saying that I can't really speak to that. That's kind of a new thing for me to think about with stigmas.
Yeah. So yeah, it's such a good question, and maybe we can talk about that a little bit more with our final discussion, which is focused on seniors in our communities. And asking for help by seniors is a factor that's been raised, or I should say, unwillingness to ask for help is a factor that's been raised in numerous studies of seniors. And so those of us who work in communities with a larger senior or elderly population have to deal with these questions around assistance of various kinds and how people ask for that, feel about it. So maybe that will come up in the next, the final group discussion that we'll have in a little while here. I think though that I'll maybe come back to our slides so that we can progress through them. I want to show you my screen here, which should be.
There's another comment in the chat box if you didn't see it.
Let's see here. I just need to get back over. Do you guys see my slides now, Emily?
Yes.
Okay, you're not supposed to see my slides. You're supposed
to. Well, I mean,
my...
I see a website. I see a.
Oh, you do. Okay.
Yeah,
good.
I apologize.
Oh, that's okay. So let me pop back over to the chat.
I know they're all in different
Julie
windows.
saying pre-COVID we had Head Start hand out short surveys just to parents about their WIC involvement. Maybe the data are unanalyzed still. Julie, that's such an interesting point that you made about pre-COVID. Pre-COVID is when the work was done. Maybe you weren't reflecting on how the COVID era has affected the way that people think about federal assistance, but my suspicion is that there will be a significant destigmatization of federal assistance programs, state and federal assistance programs because of COVID, but we're gonna have to see how that plays out. But it's good to know that you did get involved with this survey effort. I'd like to see those results when they come in. That's really interesting. All right, I'm going to close the chat box and bring your attention to my screen here. This is the healthypeople.gov website, and I've clicked on the green tabs at the top under the social determinants of health part of this website. I've clicked on interventions and resources. And there are, in this section, there is a literature summary provided for us to read through on each of these many social determinants of health buckets, as I referred to them before, or components or core areas. And I am just kind of scrolling through them so that you can see there are things having to do with employment and enrollment in higher education, health literacy, graduation, and what have you, things I've already mentioned. I also talked about social cohesion before. So that's the one I've chosen to zoom in on of these many. I can't do them all today, unfortunately, but any of these program or intervention areas that are of interest to you, I would really encourage you to pop over to this website, take a peek at what the literature says about the social determinants of health programming or programs that are out there that focus on that core area. So I'm going to stop sharing that screen and I'm going to pop you back over to my slides.